So let's take just a brief moment and take a look at cardiac issues that may arise within your pediatric patient. As kids grow up, as their cardiac system continues to develop, there may be cardiac issues that come up, and generally they're going to be some type of an arrhythmia quite frequently until they get into their early 20s. First degree heart block will be a common type of arrhythmia that you would see. But ischemia is generally not going to be one of them because kids typically do not suffer from cardiac disease. The things that we're looking here are tetralogy of Fallot or Brugada syndrome, and in particular, depending upon some medicine that the patient may be taking, we could see a prolonged QT syndrome. When we're looking at tetralogy of Fallot, basically this is a congenital heart defect that comes into play. And in essence, what we see here is that we have a large area here of where the septum that's between the left and the right ventricles now have a problem. As a result of this, what happens is we get oxygenated blood and deoxygenated blood that mixes together. These kids, quite often, when they are born, will have lots of cyanosis that does not clear up right away. And so again, in many situations, if mom has had prenatal care, you're going to be aware of this prior to the delivery. If she's not, you may not be aware of it, and you're still going to address that with rapid resuscitation. In essence, what you're seeing here is kind of this defect, as you can see right over in between the left and right ventricle. Again, deoxygenated blood comes into the right ventricle and gets shipped off to the lungs, coming back into the left ventricle to be sent out to the body. And during the pumping action of the heart, this blood gets mixed, and so there's a lower level of oxygenation that's taking place within the body. Now, there are some other things that we're looking at here, and I would like for you to go back and to review the dangers of long QT syndrome in particular. At this point, don't worry about Brugada syndrome. We'll talk more about that this summer. But again, look at the dangers of long QT syndrome, as well as some of the medications that may cause that, particularly if the child gets into a parent or a grandparent's medicine that would result in that, and how the impact of long QT syndrome has on the potential for ROT. Commotio cordis has been in the news a lot over the last couple of years, and commotio cordis is, in essence, basically just a sudden impact to the heart during the relative refractory period. And as such, these kids go into ventricular fibrillation. Now, the good thing about commotio cordis with these kids is that if there is a defibrillator available, generally it takes one shock and they are resuscitated. And that's why there's a much larger push right now to include defibrillators within the realm of all youth sports. The thing says it can causes primarily a VTAC, but sometimes third degree block. Most of the time, it's going to be VTAC or pulseless VTAC in particular, or VFib, because remember, the defibrillation does not come about as a result of third degree block. Looking at your cardiac arrhythmias, the fast, the slow, and the pulseless arrest, and understand that in respiratory issues, quite often we will see an increase in the heart rate and then a sudden decrease in the heart rate. With kids that go into cardiac arrest, generally what they'll do is they'll brady down and then they'll go into a PEA or a systole. And so the primary bradycardia that we're looking at here could be as some type of a defect within the structure of the heart. Most of the time, what we're going to see secondary bradycardia from any of the other reasons that are listed below, with the first one being hypoxia, and that's the most common one that's going to be in there. Keep in mind that when you have a slow rhythm or a slow arrhythmia in your child, this is an indication that your patient is probably close to going into cardiac arrest. Generally, what we're looking at here is we see tachyarrhythmias. We can occasionally see SVT as well as VTAC, but most of the time those tachyarrhythmias are going to come about as a result of shock from trauma. Again, remember that the heart rate for the pediatric patient, the younger they are, the higher the heart rate is typically going to be. So your assessment on your patient is going to be the same thing that we're going to do as far as in major emergencies. We're looking at respiratory, we're looking at cardiac, and we're looking at the neurologic. What we're going to be doing in here is we're going to be assessing the airway, breathing, and circulation for the patient. And we're going to utilize AFPU to be able to come into play and to assess very rapidly the level of consciousness. Again, and I know I keep stressing this, but it's really important. Generally, when you have a patient in cardiac arrest, it's going to come about as a result of a respiratory problem or the end stages of shock. Many times we're not as aggressive in the treatment of these conditions because it's kind of like we're afraid that we're going to hurt the child, we're afraid we're going to do something wrong, and we just simply ask our partner to hang a diesel drip and drive really, really quickly to the hospital. Don't do that. Don't do that. Take your time, and if nothing else, assess and focus in on the basics, and you will be doing a good thing for your patient. Again, keep in mind that in cases of shock, kids will compensate, and then literally they come right off the edge. There's a very, very short period of decompensation that happens with the pediatric patient, and they move into irreversible shock. Be as aggressive as you can, but do proper treatment, and don't hold back treatment because this is a pediatric patient. One of the things we're really good at as paramedics is that we're expecting the worst, which makes us typically good paramedics, but it also makes life very rough for us in non-emergency situations of typically being pessimistic. But in kids, always be thinking of, okay, what's the worst that could happen in this situation? Do not be hesitant to use some type of memory aid. It's really important as far as when you're doing this, don't be afraid to use a hand heavy or something else. So be really careful about over-oxygenating your patient. Again, what we're looking at here is acidosis really does have a big issue. If we have acidosis that comes about in our patient, the vasculature will dilate, and now our blood pressure will drop. The flip side of that is also true. If we are putting our pediatric patient into an alkalotic state, then we run the risk of causing massive vasoconstriction, reducing blood flow to the brain. In all situations here, make sure that you're using and interpreting end-tidal CO2 to help to guide your respirations. Kids respond really well to IV fluids. They're a booger to get IV started on, but once you get them started, it really does bring them back to the land of the living. If your kid is sick, don't waste a bunch of time looking for a peripheral vein. Go straight into the IO. Again, don't be over anxious and jump to the IO until you've done a brief cursory review of the available vasculature. But again, the younger the child, the greater the possibility is going to be that the IO is going to be the most appropriate IV for your patient. Watch your monitor, and I would tell you to turn your monitor alarms on so that as the heart rate begins to decelerate, this is going to be your early warning system. Rely on your gut. I do a lecture called Your EMS Gut, and NCI Special Agent Leroy Jethro gives, because he's well known for his gut as far as being able to identify things. So the bottom line here is that if you feel like that the child is sick, then treat them accordingly, so that you would much rather over triage than under triage your patient. Here's your APGAR. I will ask you to calculate an APGAR, but I will also provide you with the APGAR. I don't expect you to memorize this, but be familiar with it and know what each area of it comes into play. So let's take a look at a few case studies. You got a 5-year-old who's complaining of vaginal pain. She stated to her mom when she came home from her school that someone had their hands down her private parts. Mom did an exam and she didn't see any trauma. So my question would be, should the medics have visually examined the girl for assault and trauma? Pause it and come up with your answer and come right back, and I'll give you my opinion on it. So as far as this answer goes, like everything else, it depends. It depends upon how much you have as far as trust in the accuracy of mom. Look at the emotional state of the little girl as well. Many times you can just simply do an external visualization without removing any clothing to see if there's any bleeding. And again, if there is a problem as far as patient appearing to be in a shock-like state, then yeah, most definitely we're going to need to assess to see if there's any bleeding that's going on. This is a potential for sexual abuse, and again, the definition is that if a child engages in sexual activity that they can't give consent, either because of their age or developmental disabilities that keep them from understanding what they're able to do. In sexual abuse, this is basically any type of contact that comes into play that takes advantage of a pediatric patient. Generally, sexual abuse is pretty common, unfortunately, in America today. Females are much higher risk to be abused than males. And the other thing is, we worry about these people that ride around in vans who are strangers and don't understand, don't know anybody, and kidnapping the kid. But almost always, the perpetrator is going to be somebody that the family knows or is related to the family. And here's the thing to keep in mind: not only within sexual abuse, but also within child abuse, it happens across the board. Case number 2 is a 3-year-old female with a seizure. She's found incontinent of bowel and urine. When you get there, she is warm to the touch. She was taken to the hospital and given 4 milligrams of Valium rectally. Family says that she woke up afterwards, looked great, and then came back home. Febrile seizures generally occur up to 5 years old, and the thing to keep in mind, as I said earlier, is that generally what you're going to do is, with the febrile seizures, you're going to see it happen on the first day that the fever occurs, primarily because of how rapidly it spikes. Kids can sustain a much higher body temp than you and I as adults can, with little to no repercussions. It's not unusual for sometimes sick kids to run a fever of 103, 104. If you and I are having a fever of 103, 104, we're going to be in ICU. But the big thing that we're going to see here with febrile seizures is how quickly it goes from normal to how quickly it spikes. If it occurs over a matter of a couple of hours, then definitely the situation is perfect for the potential for a febrile seizure. Most of the time, these seizures are going to be finished by the time you get on the scene, which is a good thing. Do cooling. You don't want to cool your patient off too quickly because they'll begin to shiver, and that raises the body temp as well. Case number 3. You know, a 13-year-old male has been born at 31 weeks, weighs 4 pounds, tiny baby. Mama's holding him while at the mall when she slipped and dropped the baby 3 feet onto his head onto the ceramic and concrete floor. There was a large woman who then fell on the baby. When you look at this, you have significant edema to his left parietal and occipital regions. Pupils are unequal at 2 millimeters. His respirations are 92 to 100. His heart rate is 160 to 210. And the baby is in and out of consciousness as we're going through here. Generally, what we're looking at here is this baby would have a non-displaced skull fracture, which basically means that the skull is fractured, but it is not dislodged, not a problem. And the baby had a small epidural bleed. One of the things we want to watch about epidurals is that they're typically venous. And so in this situation, I'm surprised actually that they discharged the baby to go home the next day. So again, go back and review your specific areas of pediatric emergencies. Be familiar with those. We will continue with some more specific pediatric emergencies next week when we come back together. Let me know if you have any questions.